Okay, we're going to welcome Daina Pitzenberger. Daina is a Senior Vice President with JLL's Healthcare Project Development Services. And Dana's also a registered nurse, an RN. And Dana's here to talk about the latest research report from JLL. And in December, right, Dana, or I guess it was last fall, you guys surveyed, maybe you could tell me the number, but quite a few patients about how the built environment and the location of healthcare facilities impacts patient and family experience, which is obviously a hot topic among our healthcare professionals. So Dana, I wonder if you could kind of jump in or start off with what was the most surprising finding from the JLL research that was published in December? What did you learn that was most surprising to you?
Well, for several years now, we've been monitoring the different generations, and we know, just-in-time delivery of care or retail services was starting to drive a lot of the retail health decisions and how we deliver care in all healthcare facilities, whether it's in or outpatients. But the trend wasn't as high. I think a few years ago, it was probably sitting at 63%, and now it's 83. We found that it's 83% of the patients prefer a healthcare facility nearby versus a new or renovated facility. So it's still real, prevalent. Folks do not want to drive very far for care. And as the millennials grow, it's going to get worse and worse. But even the 65-year-olds, we found that they're just as demanding. They want just-in-time delivery, just like they want their food. So they want health care, easily accessible. They don't like drive times. I thought that was a big jump in that statistic. Also, the average commute, it has shrunk. It used to be they would tolerate a drive time of 30 minutes to get to care. Now it's shrunk to 20 minutes, which is really shocking. So when we decide as healthcare providers or developers where buildings need to go, we need to keep that in mind. That is a driver when you look at site selections. And our analytic department, we put that in our evaluation tools and help clients find the right spaces that fit that type of statistic.
Yeah, so for these health systems that obviously want to service their communities and neighborhoods and metro areas more efficiently, they have to do this analysis much like a retail business would, or a gas station or a petroleum business. Now the healthcare industry is in that business of being in neighborhoods, correct?
Yes, it is. It is absolutely correct, and it's become very competitive. Folks don't really. I think there's only 36% of the surveyed will look at the satisfaction of other users when it comes to selecting a provider, whether it's a physician, whether it's a hospital. The drive time is critical when you decide where to place a clinic or even a new hospital. We can tell the growth in Houston, Texas, the largest medical center in the world. They started decentralizing from the medical center and extending out into a spoke and wheel type model. And each one of the systems to gain or maintain their market share, they had to go out and they followed the loops, the 3 loops that we have in Houston, and that helps the rural patients as well have access closer to them, and folks that are shut in or folks that don't have ways to transport into the big Texas medical center. They had to go out where the patients are, or they were going to lose the market share.
It's interesting. And Dana, have you noticed as these big health systems do expand outward, have they learned over the years of, hey, we need, not just the straight up outpatient centers or ambulatory clinical care units? I mean, are they finding that they need like the specialty facilities, maybe like cancer care or heart care?
Yes.
You've seen growth in some of those more specialty facilities? I'm just curious.
Yes, my background in nursing was always rural health or community-based health. And our whole job at our hospital was to retain patients from driving 40 miles to a medical center. And as community hospitals have gotten more sophisticated, and they realize they study the gaps in the service lines, and they study the gaps of physicians. They study what their population base. It's become very sophisticated when they select types of facilities that they're going to put in their communities. That's how the community hospitals started to grow, because they realized a lot of the patients don't need to go to the specialist in the medical center. They can be handled by the physicians in the community. And also now the medical centers are driving, or the physicians in the academic medical centers are moving outward to service patients in the community, because it's it creates a better patient experience and it retains patients. That's what they want, and the care has to go out to them. So we have seen tremendous growth in all types of facilities, but also the hospital bed growth has been tremendous over the last 10, 15 years.
Mm-hmm. Quite interesting. And it's also interesting that your survey, it's so recent that it does take into account the impacts of the coronavirus, the pandemic. And I wonder if you could comment on one or two findings that are sort of specifically related to COVID-19. What have the health systems sort of learned from the pandemic, and how they could better treat patients during a pandemic?
Well, there was such a shift. We did several surveys over the last 12 months, not only due to the pandemic, but we have to constantly find out how people make their healthcare decisions and where they're going to go and what they expect for care delivery. And hospitals are really great at infection control methods, but now it's imperative. A couple of the survey items that popped up that were tremendously important or shocking was that hospital or folks are basing their decisions on where they get care by the cleanliness and the safety they feel in these facilities. It's amazing, especially now, and that was right before COVID hit. They were afraid of infections prior to that, but now more so than ever, it's the top of the mind of everyone. And patients are still not going back. We realized in the Texas Medical Center that there's still, some of the facilities are down 30, 40%, and patients are scared to go. Hospitals and healthcare providers, it's imperative that they create a safe haven when patients come in there, and they advertise as such. And I think the providers have shifted quickly. It's not so much about having to renovate spaces. It was about communicating what everyone is doing for infection control and hand washing and social distancing within their reception areas. It's how they schedule. Throughput is everything in a hospital setting. In the emergency department, the faster in, the less chances you have to cross-contaminate a patient, with one infection to another. But now with physicians' offices, it's just as imperative. And there's been a real shift in adding software programs that manage schedules better. Patients are kind of demanding, the smart apps on their phone. It's kind of like the restaurant industry. Beat me when you're ready. I do not want to wait in that waiting room. I'm going to wait in my car, and I'm going to go right into that exam room. I mean, the expectations for cleanliness and infection control are off the charts. So providers have shifted and done a great job on spreading out their schedules, not stacking patients as much, and communicating through apps and or phone, text when it's time to come in for your procedure in the operating room or your clinic visit. So it's been a remarkable finding. Even before COVID, the stats were very high in the demand.
Yeah, it speaks to that just-in-time sort of expectation. We're sick of waiting. we don't want to wait in a waiting room anymore. That's done. That's over.
That's exactly right. And the other big shift was the shift to telemedicine. Mm-hmm. Across the industry, I think the stats are anywhere from clinics shifted from maybe less than 5% in telehealth, and it wasn't, the field was growing as reimbursement changes. That the physicians have to follow where they're going to get paid. So did the hospitals. In the shift a couple of years ago, the VA had a tremendous behavioral health study for telehealth, that kind of shifted the payers' way of thinking when it came to paying for telemedicine visits. And then the boards of medicine, they, the licensure, you can't cross over, when you write prescriptions or you diagnose unless you're licensed in various states. And now they've dropped a lot of those requirements due to COVID because the shift went to 85 to 90% telehealth visits versus inpatient visits in their clinics or even in the urgent care or emergency department. So everybody quickly had to shift to that way of delivery, care delivery. Now, if they keep up the reimbursement, we'll still have a telehealth will remain for the rest of the history of medicine. They'll get more sophisticated with the equipment, cameras and such that can diagnose. The robots that sit in the ICUs and monitor patients, and the nurses are sitting, at the nurse's station, or you've got a second set of eyes in another area, not even in the hospital, as a backup. So that telemedicine is not going to go away, and it's been a great shift. I think the goals of most of the doctors, they would like to have a balance, maybe 20 to 30% of their practice, or the hospitals even would like to, have it flip back instead of 80%, and go back to the 20 to 30% goal that they have in mind. But we've noticed that hospitals and doctors are embracing it. They have to. Patients are going to demand it. They don't want to go in there because they're afraid they're going to get sicker.
Yeah, and also, and I know you are a nurse in a rural type community, and there's a huge void out there in the suburban, exurban, and rural communities, and telehealth could be such a huge benefit to those communities.
Absolutely. It used to be Medicare would make a patient go in and see a family practitioner or their primary care doctor before they could jump on telehealth, like for the congestive heart failure patients, the chronic disease patients in rural health. In fact, I had a home care company in my early days, and the only way we could get them on telemedicine's been around for 30 years. The reason it hasn't grown like it has now is because the reimbursement, if they're not going to get paid for it, they're not going to use it. Well, Medicare would allow patients in rural America, but they still had to find a doctor that would write a prescription or see them on an annual basis. And a lot of rural Americans, they don't have the means. They don't have a car. They're elderly. They're shut in. So it's now the care is going to them. They'll mail the equipment to the homes and set them up virtually. They'll send a home care nurse to set it up. It's remarkable what telemedicine is going to do for the care of shut-ins.
What are a few takeaways for most of the people watching us and reading BD+C? They're AEC professionals, so design and construction, engineering, and so on. I mean, what are some of the takeaways either from this survey or from your recent research and your experience as far as like design changes to a healthcare facility, whether it's related to just the trends that were kind of coming along pre-COVID and ramping up, or because of the pandemic, here are a few things that are going to happen for sure that maybe we're just in early stages, but you're seeing happen with your clients.
Well, we thought last year, a lot of us thought when we were talking to our clients that the hospitals would change design quicker than they have, with a few modifications from their entry points in the emergency departments, or where they do testing. They went out to tents. It's just been remarkable. We call them workarounds in the hospital setting. But what, the shift we know is probably going to happen. It's going to be what we call, there was a big drive for universal rooms several years ago, which it costs a lot of money. And what that means is every room can turn into an ICU bed. The infrastructure that you have to put in those rooms is tremendous if you're not going to use them 99% of the time. That theory kind of dropped off. But now there's a thought about maybe we do need to have universal beds, because they've had to convert 40-bed units with portable negative air machines to make each room an infection control room versus one on each floor. Or you can, in ICU, there's a few rooms maybe. but it's so important to be able to flex your spaces to infection control, maybe not on ventilators, patients not on ventilators, but golly, if you run out of ICU beds and your sister hospital you used to transfer is just as full as you are, you've got to convert regular acute care beds to ICU beds. And how do you do that and not break the bank, basically? So the architects are going to be challenged with the return on investment when they talk to the C-suite about how the spaces are going to change. And it's going to be highly regarded for those that think, how can we flex these rooms? They've already done it in the past. Architects are very creative and help us extend our staff and our patient care delivery methods. But I think they'll be ready for this challenge as well. As far as doctors' offices, there's been some talk throughout the United States that some of the doctors want to add negative pressure rooms. Those are infection control rooms in their clinics, but the infrastructure, like I said, is costly, and that will impact their cost of leasing their lease space. And is it worth it? And a lot of times, if you just have one room, that's not gonna make a dent. So their spaces will embrace maybe larger waiting rooms, larger exam rooms, egress, one way in, one way out, so they don't cross-contaminate patients with each other. Maybe they'll look at more on board where patients enter from the outer halls into exam rooms. They never see a nurse's station, and they never leave that room. Everybody comes to them, and then they go out the opposite way they came in, creating a more, not a sterile environment. It's possible to do that in a clinic, but a more cleanly environment. So architects are going to have to rethink on clinics of the future and in all facilities of the future. How do you social distance? This isn't going to go away. There's a couple of more viruses that have come out of, or a couple more viruses that are sister to COVID. It's just, we've got to be top of the mind when we are designing spaces for the future. So those are probably the biggest things right now. And then accommodating telehealth as well in the physicians' offices, converting office spaces into a telemedicine room. The acoustics have to be there, the lighting has to be there, there has to be great cameras. That could be an exam room or an office conversion. That's pretty easy. Some hospitals are embracing telemedicine centers of excellence. I think there's 3 or 4 in the United States where they've offloaded all of their telehealth from their robotics that are watching ICU patients, NICU babies, home health patients, and they've moved them into MOB-like settings that are built kind of like data centers. So there may be a surge in that type of facility as well as we get more sophisticated with our telehealth equipment.
Yeah, we've written about Mercy Virtual Health. That was an interesting facility a few years ago. And I think we might see some more dedicated spaces related to telehealth in the coming.
Oh, yes, I totally agree.
Daina, thanks so much for your time. This is great stuff from JLL and your team. And we'll check in with you maybe in a year and see where healthcare is at.
Okay, great. Thanks so much for having me.
Thanks, Daina. Take care.